Okay, and another quickie lecture as well. What we're going to quickly talk about here is insulin, when we talk about as an add-on to insulin therapy, and then
Oral
we are going to
antidiabetics,
talk
type
about
2.
oral medication. So, oral antidiabetic agents. So these are, remember your pathology. Type 2 diabetics are producing insulin. The insulin is just used inefficiently within the body due to one of two things. And the pancreas is not producing enough, or the sensitivity of the cells to insulin has been decreased. So we are going to give you medications that will do one of two things. Guess what? Before I even get into this rest of this lecture, guess what these oral medications are going to do? Stimulate the pancreas to produce more insulin. And, or, number two, make the target cells more sensitive to insulin. That's it. That's the two main types of drugs that we are going to talk about throughout this entire lecture. Those are the key components that you need to know about oral type 2 diabetic medications. And I keep saying oral because you don't give these drugs any other way. And I know you watch CNN, they're coming out with some newbie ones and everything like that, but those aren't the common ones you're going to see. We're going to talk about the most common ways of treating type 2 diabetes other than insulin in advanced stages. So you've got to think of the patient right now, walks in a doctor's office, overweight, has high blood sugar, and has no exercise, does everything wrong. They're probably going to go on an oral antidiabetic agent. So, used to lower blood sugar, used to treat uncomplicated type 2 diabetics who do not respond to just simple diet control alone. Appropriate for use in type 2 diabetics who are usually less than 40 years of age, not overweight. Require, and the way they do this is they say they require less than 40 units of equivalent insulin a day. So this is where people ask, so when do you start using insulin instead of using the oral anti-glycemics, blah, 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 blah. Well, there is a marker, and the marker is this. If we were to take you as a type 2 diabetic and start giving you some insulin, okay, as an experiment, let's give you some insulin to bring your blood sugar down. If we take a whole 24-hour period and go, hey, you know what, look, to keep the blood sugar for this type 2 diabetic where it needs to be, we only needed 30 units of insulin. Well, that person is a good candidate for going on oral anti-glycemics. If they require 40 or more, if they require more than 40 units a day, get the same person in 4 months later, and now they're requiring the equivalent of 50 units of insulin to bring their blood sugar down. They are not. They quickly become not a candidate for oral anti-glycemics and start to actually then tend towards using actual insulin. Okay. So there's basically two main types. There's these things called sulfonylureas, which are basically sulfa-based drugs. And we see non-sulfonylureas, surprise, surprise, and then there's some other new drugs over here. These are the main two categories that we're going to talk about, okay? And glybuteride, the big one that you've probably already seen, and then we've got these other classifications over here, bigantamines, thiothiazines, and megalantines. This one is similar to sulfur. The reason why this one is here is it has similar effects as a sulfonylurea, but it is very chemically different, so it is called a non-sulfonylurea. So, mechanism of action of how these generally all of these sulfonylureas or non-sulfonylureas will do is they will stimulate production of insulin. They will increase the sensitivity of the insulin receptors, or I know I talked about those are the two main biggie ones. Or the other thing that these drugs can do is they can inhibit the absorption of sugar in the GI tract, or they can excrete glucose. They can promote the excretion of glucose through your kidneys. These medications are not insulin and should not be given to a type 1 diabetic. Okay, what they usually do is these are drugs that are usually I would call them indirect bloods. They're not like insulin where they directly reduce your blood sugar because they're insulin. They indirectly lower your blood glucose by either making you produce more insulin or making you use the insulin that your body is already producing more efficiently. Okay? And that's why I said we're increasing the effectiveness of endogenous insulin, your own personal insulin. Mechanism of action of sulfonylureas. So every drug that falls under this category of sulfonylureas, okay, we're going to talk about the mechanism of action. Devised from a sulfonamide group of antibiotics. So we actually found out, hey, we put these people on this type of antibiotic, their blood sugar drops. What the hell is going on? And what they do is it's a stimulant. It stimulates the pancreas to produce more insulin. Cool. And by doing so, it decreases liver gluconeogenesis. May also, and this is where it may increase the peripheral use of glucose and decrease production in the liver as well. It alters receptor action to increase the cell's response to insulin. So what this does is the sulfonylureas do two things. Stimulates the pancreas to produce more insulin and increases the sensitivity of the target cells to insulin. Those are two biggie things that sulfonylureas do. And you can even see this pretty diagram what it will do. Okay, it does two things. One, it plays around, it goes in here and it causes the beta cells to produce more insulin. Fantastic. Okay. The other thing it will do is it can cause some issues with cardiac issues. But what it does, main thing it does is right here we see it actually stimulates the pancreas to release more insulin, which is great. Adverse effects, okay, things that we can sort of deal with, includes hypoglycemia. It can cause some bone marrow suppression. It can increase the risk of cardiovascular disease. It can cause edema. It can cause some photosensitivity, some seizures and weakness in the central nervous system. And notice I have split these up in systemic categories. Also, GI can cause some diarrhea, constipation, flatulence, and some nausea and vomiting, and it can cause some anorexia. It may complicate some respiratory issues, and where you can think of that is if you go back to the previous slide where it says it also screws around with the heart a little bit. Well, it can screw around with some respiratory issues by causing issues in cardiac blood flow. Administration, it usually is given with food until glycemic control is reached. And then that's it. That was it for non-sulfonylureas. The big one, as you can see, is glybuteride. I'll probably use that one on the test. That was the sulfonylureas. Okay, and now you see also why, when we were looking in the lecture on insulin, we saw in that lecture that you have to be careful giving insulin to people who are taking any sort of drug that is sulfa-based. Okay, that's because these sulfonylureas, that component, and we see other drugs that are sulfa-based drugs that are used for other purposes. When you go into semester 3 and you talk about sulfa-based drugs, guess what adverse effect it might do? Drop your blood sugar. Because you should remember that in semester 3 because of what you're learning right now in semester 2. Okay? So, non-sulfonylureas, we basically have these things called bigantines, metformin. Everybody sees metformin. You probably have a lot of patients on metformin. It is the most common oral antidiabetic used in Canada. This prevents a sharp rise in blood sugar from occurring in the meal. Does not produce hypoglycemia. Why? Well, the mechanism of action is slightly different. So this is why you're looking at the sulfonylureas or non-sulfonylureas. This is why this drug is so popular in Canada. It does not cause hypoglycemia. What it does is the following. It decreases the production of glucose in the liver. It promotes glucose uptake by cells, so it's probably playing around with the sensitivity of those cells, right? So yeah, it promotes glucose uptake. It plays with the insulin sensitivity of the target cells. It also delays digestion of glucose, so makes you use the little insulin you have in your body more effectively, causes a slower digestion of in your GI tract, which means a nice slow release of glucose into your bloodstream instead of a big spike. And it stops the overproduction of glucose by your liver, so it shuts down that glucagon glycogen pathway as well. That's pretty good. It allows you to use what you got, but use it more efficiently. Okay, so some adverse effects. Blood, really, there's none. Hey, I like this drug already. Does not cause hypoglycemia. Fantastic. These are actually bonuses. GI can cause some bloating, nausea, cramping, and diarrhea. Well, look at this. This drug has got far less adverse effects than the non-sulfonylureas. Cool. These adverse effects are usually transient too, so all these GI effects are transient and can be limited to titrating a meal, meaning taking your meal, titrating the medication to the meal. This is why we like metformin. Now, so that was pretty simple. You basically remember remember everything that the sulfonylureas do and why it's so bad, and that's why you know we like the metformin better. Now there are some other ones as well that are becoming more vogue. Pyrrolidazole and rostolizolazone, and they're part of this thing called the thiazolidinedione, whatever this, I can't pronounce anything this morning, sorry, I'm lecturing too much for the last 3 days. What this basically does is these play around with insulin sensitivity and allows the insulin to work better in muscles and fat in the body. We have this other one over here. You notice I'm not getting too heavily into these ones as compared to the other two. These ones as well, the megantines, they stimulate rapid short-term insulin secretion. So what I would probably focus more on is when we talk about these other non-sulfonylureas. The previous slide, look at what that one does. And if you look at what the metformin did first, right? Metformin played around with insulin sensitivity. The last one, look at what it did, okay? And what did it do? Did it play around with insulin sensitivity, or did it play around with production? This one right here, and the last one we just talked about, the thio whatever thing, played around with insulin sensitivity as well. This one right here, we see that it stimulates short-term insulin secretion. So what I would do, if I were smart, and I am, I would understand which one of these increases insulin production, which one of these increases insulin sensitivity, and which ones of these does both. Okay? That is more likely to get you a lot more marks on your next test than anything else. And this one can be used in monotherapy or in combination with metformin. Why, do you ask? Would you use it in combination with metformin? Because does metformin cause an increase in production does it cause an increase in production from your pancreas? No, it does not. Metformin does not do that, which is why we like it. It screws around with GI absorption. It screws around with the insulin sensitivity. Okay? It does that sort of stuff. Okay, this one here, so what if we wanted to have the bonus of not having a drug that we just want to gradually increase? Because remember, if you go back to the sulfonylureas, one dose does both. It does sensitivity and it does insulin production. So here, if we wanted to titrate a little bit and maybe just boost your insulin sensitivity and also and boost up your production, but just boost the production ever so slightly, then this is why you would use a combination therapy, okay, with metformin, okay? It's because of what the drug does. This other ones over here, these alpha-glucose inhibitors, guess what? Glucosidase inhibitors. Guess what it's probably going to inhibit? Because remember I said that there's some of these drugs, is one of the things they can do. There's a drug that will inhibit the absorption in your GI. Guess what? These drugs stop you from absorbing drugs, or stop you from absorbing glucose in your GI tract. I consider this the lazy man's drug, the one, what I would call the Donald Trump drug. I don't want to stop eating my burgers and fries every day and decrease my glucose, my carbohydrate intake, so I'm going to take a drug that basically makes me poo it out. Fantastic. So this causes only a small spike in blood sugar because it does not, no insulin production, no hypoglycemia. It helps you maintain your diet for people who don't want to eat more veggies. So some of the new drugs, these are not in your text, okay? These are what we call sodium glucose cotransporters. These are drugs that will target the process of renal glucose reabsorption and increase basically glucouresis. Basically means your blood sugar spikes up and you basically force your kidneys to actually pee out the glucose. Okay? These work independent of insulin or its action. Again, I call this a lazy man's drug who will not actually comply with diet changes.